right, guys. So, so let's start our lecture. Sorry, I'm going to stay chained to the desk because I'm taping for, hopefully this tape comes out. I usually use this one at home when I set it up, but this is a state school, so all of our computers are just a little bit behind the times. Okay, so we're doing advanced central perfusion. Yes, this is Professor Stone's PowerPoint. As you can tell by the higher level of content, we'll scale. I'll tell you what I really want to know because I already. All right, the objectives are on the real objectives are on syllabus C. These are great objectives, but the objectives for the actual class content are what we test on. So on syllabus C, those perfusion ones are what we're testing you on. All right. So valvular heart disease. So what do the valves actually do? What are we thinking? What do valves do to your heart? What are this? Right, they're little gates, right? And they prevent backflow of blood. So what happens when you have leaky pipes? Does the system work well? If you flush your toilet, do you want some of it to flow back every time? Or do you want a nice, fresh, clean bowl, right? That's really what, like, if you think about it, your heart is a fancy toilet because what we're doing is we're recycling the blood through the lungs, getting rid of all the garbage, and then it comes back. Well, we have a leaky toilet. Okay, so stenosis is the tissue thickens, right? So we get basically scar tissue on the leaflets of the valve. Not only does it not open well, because it's stiff, but it also doesn't close well. So it's just a crap valve. It's awful, doesn't work, all right? Insufficiency, same thing, but it's not as stiff. Regurgitation, so we get a little, every time the pump is supposed to be nice and tight and closed, you get leakage through. What do we hear when we auscultate a patient when they have something like this? If we're listening to somebody's heart and they have a leaky valve, what do we hear? Murmur, right? And what does a murmur sound like? It sounds like a leak. So instead of lub-dub, 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 so we may get lub-sh, lub-sh. Or the other way around, we may get whoosh, dub, whoosh, dub, whoosh, dub. Or if it's pansystolic, we'll get that lovely whoosh, 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 whoosh sound, okay? That's a murmur, all because of the valves. So if you have a bad valve, if you're lucky enough in clinical, you may actually get to hear it, right? Not all of them are very loud. Sometimes it's a teeny little leak, and sometimes it's a massive leak, and the sound commensurates, right? So you'll hear them talk about the grade of murmur, how loud it is. It's got to be pretty damn loud for me to hear it, because I'm not a cardiologist who spent 8 years in school plus another 4 years of fellowship, and then, okay. But if I hear a murmur, I know, oh, if I can hear it, it's probably pretty bad, right? Okay. And then mitral valve prolapse. What does that mean? So think of, sorry guys who aren't here, you're not going to see my hand gestures. So think of the valve like this, and it goes down, it opens, the gate opens, and then it closes like a gate, right? Well, with prolapse, when the pump actually goes off, when the muscle squeezes, they kind of bow up. So, you know, they're not really doing their job, and that also impairs the pushing part, because if the gate goes back, then some of the cardiac output is affected. That's what okay, so what does this all mean? So we are going to show signs of heart failure because we have leaky pipes, so we have a broken pump. That's what happens. All right, so guess what? We all learned about right-sided versus left-sided heart failure. No. What side is the valve on? Okay, not that hard. Okay. All right, so what kind of assessment that we do on everybody? So we're going to ask them all kinds of questions. Family history. Does your dad have severe mitral valve disease? Well, maybe that predisposes you. Do you have a history of rheumatic fever? So if you have rheumatic fever, it can cause rheumatic heart disease. It can cause damage to the valves of your heart. We've all heard this story, right? Recent infections or invasive procedures. Or are you just really tired? Sometimes patients come in and they're like, oh man, whew, I have just been exhausted. And they don't understand why. And then they take them in and they do an echo or they hear a murmur. And they're like, yeah, you've got a pretty leaky valve going on. Of course you're tired. Bad pump, bad cardiac output means impaired oxygenation in your entire body. Of course you're tired. All right. So we want to maintain cardiac output. Easy to say, hard to do, right? Prevent complications. We want to prevent infection. Anytime we have turbulent blood flow in the heart as well, it can increase the risk for clots. All right, so sometimes those valve issues not only cause impaired cardiac output, but they can cause turbulent blood flow, and it can increase your risk for stroke. All right, so heart failure, duh, dysrhythmias, and then we want to control the symptoms. So we want to fix your shortness of breath if we can. If this is causing pulmonary edema, what medication do you think we're going to stick them on? A little bit of Lasix. We may give you medications to help the push. What are those medications called? The inotropes. Like, I am going to pump you up. Inotropes, okay? They help with the pump, all right? And patient teaching, right? So if you find that you get fatigued when you climb 6 flights of stairs, then maybe you should take the elevator. No, how do you control your symptoms? Managing, if you're exhausted all the time, clustering your activities and so forth so that you're not exhausted. All right. So nursing diagnoses. So knowledge deficit. They didn't know they had one, and now they know they have a valve disease. And what does that mean? A lot of people are not medical. They have no idea what we're talking about. Valve surgery or altered tissue perfusion related to valve abnormality, right? Okay. Altered cardiac output, yada, 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 yada. Bad pump, all right? So what do? We want to keep this from getting worse, right? How do we optimize someone's central perfusion? What are some things, let's think back. I know it was a long time ago, but let's think back to 1010 when you were introduced to this concept. What kind of things do we do to optimize central perfusion? What? O2? Well, we can if they require it, but how do we keep what they've got from getting worse? What kind of things should we do? Any thoughts? Well, if they're eating that double Big Mac and fries with extra salt, that might be something that they can trim back on. Now, I would never tell anyone you can never go to McDonald's again, but I would say maybe we should limit the extra salt on the fries and go with the small. And, so salt intake can definitely affect our central perfusion, right? And increases your risk for heart failure if you're prone to that, okay? Minimize your risk of complications. So sometimes if we have turbulent blood flow, just like our patients with AFib, once in a while these patients are placed on something prophylactic, okay? Patient education. Signs that they need to look out for. Hey, Donna, if you put 5 pounds on in 2 days, that's bad, right? Start weighing yourself every day. What is that extra 5 pounds in 2 days? Fluid. If you're showing signs of right-sided heart failure, what do those include? Edema, right? It's a backflow. The flow coming back can't even get into the heart, and your peripheral circulation is overloaded with extra fluid. So we're going to show signs of edema and weight gain. And what kind of edema is it? Peripheral, and it's usually pitting, right? That like congested, shiny, students love when they can stick their finger in and look, my fingers are right there. Okay, so lots of patient education. All right, left-sided heart failure, what are we worried about? Pulmonary edema. So if you notice that you're getting really short of breath, who should you call? Your doctor, right? Or if you're really short of breath, where should we tell them to go? The emergency room, because that might require some extra measures like some IV Lasix or, a night in the hospital. Okay, so surgical. We have a bad pump. There's only so many things we can do. We can do surgical repair. So we can either replace the actual valve, like take it out and put in a new one, like brand new gate, Or sometimes there are procedures that we can perform to kind of loosen it up if it's stiff, all right? So repair perfusion, we can do a valve, I hate these words. She always puts these big words in. Valve repair, valvuloplasty. We repair it and we suture torn leaflets. So if they got ripped or so forth, we can actually go in. It's not as invasive, right? Because where are the valves? Are they inside the heart muscle or are they inside like where the blood flows through? Blood flows. So sometimes they can do fancy schmancy things where they thread a catheter in. Wouldn't you rather have that than them sawing your sternum open and you have a brandy new special scar on your chest? Okay. Annuloplasty, and again, they tighten and suture, all right? Or the commissurotomy, valvotomy. You're killing me. That's when they enlarge the opening with the balloon. So again, they go in with a catheter and they pop the balloon open and it can kind of loosen the stiff stenotic valves, all right? All right, and then valve replacements, all right? I like this slide. Mechanical prosthetic valves, all right? So those are mechanical, i.e. made of metal, right? Do we stick plastic pieces in people if we can help it? No, we don't stick plastic to stay in people because it doesn't last very long. So we use like surgical metal. These can fail though because they're made of metal. They're not, meant to last 1,000 years. These are the ones. Has anyone gotten to hear one of these? They're actually really cool. You hear a click during the, it's actually really neat. I love listening. I'm like, oh, excited. And then I ask permission. I get everybody to, all right, is it all right if all 8 of my students come in and listen? Because they probably won't hear this anywhere else. And they're like, okay. All right, here's the thing. If we're using a prosthetic, like one we made, they are on Coumadin for life. All right? Have you watched those Xarelto commercials? And they're like, oh, it's good for AFib not caused by a valve replacement. That's why. Because you can't use the anti-10A ones. You're on Coumadin for now. There's the FDA still like, those drugs are relatively new. They've only been out for like, God, when did that one come out? I don't know, 7 or 8 years. And so they're still studying the effects of how well they work on patients with artificial heart valves. Okay. Right now, it's Coumadin. So what teaching are you going to do with these patients? Your warfarin sodium education, right? Because you're going to be on Coumadin. And what's the therapeutic INR? 2.5 to 3.5. That's what we're looking for on these patients, okay? And yes, there are different kinds. Am I going to test you on the Star Edwards ball cage versus the St. Jude bileaflet? No. Are you heart surgeons? No. Does it matter to you as a nurse? No. So what you need to know is how to take care of your post-op patient and what kind of teaching you're going to do, all right? So if you had to have a valve replacement, what kind of surgery is that? Is that minimally invasive or invasive? Oh, it's super invasive. It's open heart surgery. Because they can't just like go in and pull the little sucker out. They got to cut it out and sew in a brand new valve. All right, open heart surgery, sternal incision, big deal, okay? Again, you're not performing the surgery or deciding if it should be performed, and I don't expect you to know how to put it in, but you should know that this is a big deal. And if they're getting like a metal one, it's Coumadin for life, so they're going to need that education very clearly. And a nutritionist is probably going to have to come in. That's one of those interdisciplinary, things, right? And they're going to need some kind of rehab, right? Cardiac rehab. Just like slice open somebody's heart and go, okay, you can go home tomorrow. Here's some instructions, right? Okay. Did she put that in twice? I think she did. Okay. Now, here's the bio-prosthetic valves, all right? So we can get a donor one, or we can use a porcine. What's a porcine valve? That's a piggy. This little piggy went to market and lost his heart, and now we're using it. And we're using it to save somebody's life. That's really, they kill a pig and they go, okay, this part's for Bacon, and then this part is for Ralph, and he's going to get a new heart valve. Now, they harvest them very differently, but in a way, that's what they're doing. Okay, so they can calcify, meaning it's a biologic thing. And is it originally part of your body? No. And your body goes, whoa, 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 this doesn't match. It doesn't usually get rejected, but your body may go, let's just cover that with a little extra calcium just to make sure that it's not going to bother anybody, so it can form calcification. Okay. But here's the nice thing about it, is it doesn't require lifetime Coumadin use. They only give you 3 months of Coumadin. So that's the nice part about this. So, okay. And then again, she has all these, she's a wonderful, fabulous, brilliant person, but she has Carpenter Edwards porcine, and I don't care, all right? Like, is it a piggy one or is it a mechanical one? It does make a difference for that, okay. The Hancock, the standard and modified, minimizes the risk of leakage. So how do we figure out if you have a bad valve? You have a bad valve. You have a bad. So one of the earlier tests that they do is an echo. All right. So your patient is they hear a murmur, or the patient's really short of breath and is showing signs of heart failure, and they can't figure out why. And they schedule your patient for a 2D echo. Patient's like, oh, what's that? What are you going to tell them? Yeah, it's an ultrasound. Does it hurt? No. Do they need to do any real special prep or anything? No. Come in, lay on the table, they pour some, I always sound like, don't wear your pretty bra that day if you're a girl, because you're going to have some, goopy stuff that you got to wash off. If you're a woman, it can be a little invasive feeling. So if I have someone with a history of sexual assault or whatever, I explain to them very carefully, this is what the test is going to do, but they're going to maintain your privacy with a blanket. All right. The guys, I tell them, if you're really hairy, they're going to have to shave off some of your hair because they put electrodes on your chest. So they do a continuous ECG while they do parts of that ultrasound, right? So, you're growing, the Everglades up there, they're going to have to shave it all off. All right. So, it doesn't hurt. And what do? The ultrasound, they can see the blood flow as it goes through. Now, if they don't get a good enough picture, sometimes they can do it the other way, and they actually can scope you, and that's an invasive one, right? Okay. There's also the MUGA or MUGA, and the MUGA, and that's a more invasive, where they inject you with radioisotope, and then they use a computer to map the blood flow. That's a really specific one. But for the majority of patients, it's done with an echo. Okay. They can take a chest x-ray too. Is it a valve issue, or do you have a gigantic aneurysm that we can see on x-ray? So yeah, for the echo, the transthoracic or the transesophageal, that's the, I'd rather have the outside one. Though, if they're going to do the transesophageal, the Versed might make it worth the day. I'm just saying, I can totally see why people get addicted to Versed, because totally, it's a fabulous benzo. So they're going to give you a little sedation. So that's the kicker. So if they have to have it, I'm like, the plus side is you're going to feel really good after they do that test. So plus side to everything. All right.
Can I ask a quick question?
Yeah.
How do they normally diagnose aneurysms, or are we going to get to that?
So we're going to talk about aneurysms, but usually they're picked up, a lot of them are picked up on a chest x-ray, believe it or not. Have you ever noticed why they like to do a chest x-ray before they send someone down for a chest CT? Have you ever wondered why they do that? And in a lot of places they will. They will send you down for for a chest CT to rule out a pulmonary embolism, and they do it with IV contrast. That IV contrast goes in at such a high rate of speed that if you had an aneurysm, it would probably take care of that for you in a hurry. So a lot of times they will do an upright just to make sure you don't have a gigantic aneurysm waiting to pop with the high pressure of the dye. So that's all. You will see that a lot of them will do a chest X-ray first, or they'll put them in the scanner and take a look-see. Because once you're in the scan room, you're like in the X-ray. So sometimes they'll do a preliminary just to make sure that you don't have an aneurysm first. But they like to make sure that there's nothing ready to pop before they shoot the dye in. Okay. The question was, I totally forgot. Oh, the aneurysm. Okay. All right. For our people at home. All right. So tricuspid stenosis. So bad valve, bad pump. So signs and symptoms: easily fatigued, a fluttering sensation in their neck. So which side is the tricuspid on? The right. So what side heart failure symptoms are they going to mimic? Right-sided heart failure. So they may feel some jugular venous distension, which is what you get that fluttering in your neck, cyanosis, and right-sided heart failure. Okay? So treatment would be like we would for right-sided heart failure: low sodium diet. It really does rarely, you rarely will hear just a tricuspid problem. Usually they have problems on both sides. So it really rarely occurs alone. So they'll replace the valve. You got a bad valve, we're going to replace the valve. All right, or fix it or dilate it. Okay. Or insufficiency, again, right-sided heart failure, anorexia, nausea and vomiting, okay? Seesaw chest movements during respirations from an enlarged right heart, okay? If the right side of your heart is failing, it has to work harder, and the muscle's getting bigger, you're going to get that. Aggressive medical treatment, okay? Sometimes this comes from infective endocarditis or rheumatic fever. IV drug users can get this from shooting nasty stuff into their veins, and all that crap swims around, and then the buggies go where? Sit on the leaflets of the valve and hang out. Whoop, have a whoop, whoop party. I had a clinical group a few years ago at Memorial, of all places, and they're closed now. Let's speak, well of the dead. So the of the hospital, not the patient. So he told my students straight up. He's like, yeah, I've been shooting stuff in myself for years, and he was there waiting to be transferred up to Boston for a valve replacement, and he was only 26. Felt really bad, but he was a great patient to have because he had awesome murmur, and he was a straight shooter, no pun intended. He would tell you straight up, like, oh, and he had the worst teeth. Your meth users too will have the worst teeth. Remember, there is a direct correlation between gum disease and your heart, because you do bad, you have nasty, yucky gums, and then you floss your teeth. Where is all that bacteria going to go? It's going to go into the bloodstream, swim around. So that's the other part of this when we start talking about valve replacements, is what do those patients need to do before they have any dental procedures? Prophylactic antibiotics, right? That's actually anybody who has anything implanted anywhere in their body. So if you have a knee replacement or hip replacement, or you have an artificial, I don't know, left testicle, no, I'm kidding, those we don't have to worry about. But if you have something implanted with metal pieces or plastic or anywhere in your body doesn't protect or roam those areas, because it doesn't protect it because it's not part of itself. So that's where bacteria find a safe haven. So if you have any kind of oral surgery or an aggressive cleaning, you have to have antibiotics beforehand. Okay. Ooh, how are we on time? Okay, we're great. All right. So pulmonary stenosis. So where is this valve? All right. It's going to your lungs, right? The lungs. Pulmonary stenosis, pulmonary. Dyspnea, fatigue, syncope, chest pain, right-sided heart failure. Usually requires no treatment, though. All right. I've actually never taken care of a patient with a replaced. I've never seen a replaced valve. Usually they go in and they kind of suture it up, all right? So valvotomy, so they'll do a repair. Apparently you can do a pulmonic valve replacement, though I've never taken care of a patient who needed one. So that might be Professor Stone's area of expertise. She might have seen that. Pulmonary insufficiency. Again, unless it's really bad, you're not going to see symptoms of this, and it's usually an extra finding. They did the echo, and they're like, oh, by the way, you have some pulmonary insufficiency, but it's usually not as marked as like a tricuspid or a mitral valve, okay? Again, they can go in and repair that one. Mitral stenosis, that's the big, all the mitral valve, like the prolapse and the stenosis, that's the one you hear the most about because it affects the big gun, right? It affects your left side, the big muscle, right? The one that does the most pumping, and so it's the biggest gate, and it's the one that has to hold on the tightest, and that's the one we see the most failure with. So mitral stenosis or insufficiency. So you're gonna get some left-sided failure, right? Which includes what? Pulmonary edema, right? And impaired cardiac output in the first place, all right? So pulmonary congestion, decreased cardiac output, that's the big pump, the big gate. Right ventricular failure. Why? Because if it starts on the left, it's gonna spread to the right, right? Dyspnea, hemoptysis, orthopnea, and angina. So you can get chest pain. Anytime you have impaired cardiac output, you have the risk for cardiac ischemia and chest pain. Why? Impaired cardiac output.
Your coronary arteries may not be getting enough oxygen.
Yeah, because your heart is a greedy bugger, and the first thing it feeds every single time is itself. Feeds itself first. It takes care of itself so it can take care of you. So if your cardiac output is impaired, the first thing that feels it is the heart itself, and it may represent chest, so they may feel chest heaviness with this, okay? Mitral insufficiency, again, pulmonary hypertension, right-sided heart failure, dyspnea, fatigue, dizziness, syncope, all right? So they're either gonna fix the valve or they're gonna maximize your cardiac output with meds the best they can and hold off surgery as long as possible. But if the patient is young or very impaired, they are going to probably replace that valve, all right? Wouldn't you rather, like, if you're, you know, like my 26-year-old friend, he would get winded just walking down the hallway. 26. Nope, they were gonna send him up and get him a brand new valve and hopefully improve the quality of his life. And he was saying, oh, you know, he used to talk to me all the time. He's like, you know what? I'm gonna go back to school and maybe I'll be a nurse. I'm like, come on down to CCRI, you know? Hey, we all deserve a second chance, right? Okay. So left-sided heart disease, all right, mitral valve prolapse. Remember, prolapse is when instead of it, you know, it just kind of buckles up and we lose some of that squeeze. So we have a floppy valve, Barlow syndrome, billowing mitral valve, and it's pretty common, okay? So unfortunately, because we're losing some of our output and our kick, we're gonna get chest pain and palpitations and syncope, all right? So beta blocker for tachycardia. Anytime your heart, your cardiac output drops, your body's gonna try and compensate by speeding up, right? Because it's like, oh, I'm starving, speed up, bring more food to me, bring more food to me. And unfortunately, it makes itself more tired that way, doesn't help. If you have a great runner's, you know, heart and you're running and you're healthy, then you need that speed up to improve oxygen demand. But if it's speeding up because it just can't feed itself, then that's bad. So we'll give it a chronotrope, which means timer, right? Chrono, slow it down. So we're gonna give it a beta blocker, right? For tachycardia and PVCs. And what are we gonna do? We're gonna replace that leaky valve. All right. Aortic valve, left-sided valve disease. So aortic stenosis, again, angina, chest pain, syncope, left-sided heart failure, and then goes from left to the right. Starts on the left, ends up on the right. So then we end up with a bad, sick heart on the whole. All right, so I love this. Without treatment, if symptomatic, death within 3 years. She's so blunt about that. So yeah, you need to fix the valve. All right. Aortic insufficiency. So which valve is this? Which aortic valve is right next to the aorta? So we're at the exit. So the exit to your heart isn't working well. So aortic stenosis, remember, stenosis means that it doesn't open well and it doesn't close well. It's just overall crap. So the exit hole is smaller, and then it doesn't close all the way, so it's leaky and it doesn't close well. Just, ugh. All right, that's why she says death within 3 years. All right. Insufficiency. It's all right, but not working as great as it should. Dyspnea on exertion, so tired, fatigue, heart failure. All right, the whole thing is heart failure, heart failure, heart failure. All right, so we want to help with the push a little bit. So some DIG, right, which is our inotrope, diuretics, and then surgically repair the valve. All right. So she wants you to remember the difference between tissue and mechanical heart valves. What's the big difference for you guys as a nurse doing teaching? So what? Coumadin. How long do you need your Coumadin for? So mechanical, life, the bioprosthetic, like Piggy, 3 months, right? Okay. And remember, insufficiency means the same as regurg, right? All right. So regurg and insufficiency basically mean the same thing. Stenosis is when the whole valve itself is just like fibrotic and stiff, and it doesn't open well and it doesn't close well. All right. Okay. So cardiomyopathy. All right. Cardiomyopathy just means what? The muscle itself is something's going on with the muscle. And it usually means, and we'll go over the types. Okay, so there's 3 categories based on what's going on with it. It's either primary, meaning we know we don't know what happened. So primary cardiomyopathy, your heart's sick, and we don't know why. Or it's secondary, so something caused it. Okay. All right. So heart disease related to unrelated to other cardiovascular causes, right? So if I have severe hypertension and that causes heart disease, we know why, right? Otherwise, we're calling it a cardiomyopathy. So it's seen in patients with heart failure and cardiac enlargement. So we have these, circle this, you need to know this. Hypertrophic, congested, which is dilated, or restrictive. You need to know the difference between those 3. A little star on that one, all right? And we'll go over each type. So how do we diagnose it? Well, we're going to look at an EKG. You're like, EKG, doesn't that just show rhythm? Oh, it tells us so much more. Echo, cardiac cath, and nuclear studies. So we're going to scan the heart, but you can see cardiomyopathy on a 12 lead. You can't see the extent, but you know it's there, okay? All right. So dilated, congestive. Cardiomyopathy is a large, dilated, flabby ventricular muscle. All right? So we have a big, floppy muscle that overfills and doesn't have the push required to get what's in it out. All right? So we're going to end up with failure here. This can lead to ventricular overload in CHF. Right? So it's all stretched out, you know, like, I could get very crass here. I don't know you guys well enough yet. All right, so it gets very stretched out, and it doesn't have the push power to push what's filling it up back out into circulation. Myocardial biopsy can lead to a definitive cause. Sometimes there is a disease of the heart, and they can do that with a biopsy. This is a big one, so circle this. May be caused by alcohol abuse. All right, and we can sometimes reverse this if they quit drinking. So you can see this a lot with your tipplers, right? It must be, I'm Irish, so I'm not, you know, but, so it must be big in Ireland. That's all I can guess. Knowing from my family, this must be like the #1 cause of heart disease. That's probably incorrect, but yes. So star on that slide. All right. So what are the signs? Gradual onset. Does this happen overnight? Do your muscles get big or floppy or, you know? No, if we're going to have it, it happens over a period of years. So we're going to have left-sided heart failure, okay? Dyspnea, fatigue, all the signs that we worry about. Emboli, Remember, whenever we have like not great blood flow, everything doesn't pump the way it should, we're at risk for clots. Moderate to severe cardiomegaly, so the heart's going to be bigger. So if we took a chest x-ray, we could actually see it on the x-ray that it's big, too big. And that's where whenever you have a large muscle, you're going to have, it affects the size of the spikes on your EKG strip. So when you look at a 12-lead EKG, on the V leads, if the spikes start touching each other on the paper, have you ever seen a 12-lead? Okay, the QRSs, when the QRSs start to kiss, that's a sign of cardiomegaly or a sign of cardiomyopathy. So that's how we can tell on an EKG. We can do an echo, right? Ultrasound, whoa, that's a big old ventricle we got going on, and it's not doing a really good job. Muga scan, that's the one where they inject you with the radioisotopes and they look at the blood flow, and a cardiac cath, all right? So, if it's caused by inflammation, we can treat it with steroids and immunosuppressants, right? If we have CHF, we can give them some DIG, help with the push. If the problem is that the heart can't push everything out, we can help you push it out with some medications. Diuretics, if it's overfilling, we can help it not fill as much. Vasodilators to help with the outflow. So if the body can't push, the pump has to push against systemic vascular resistance, right? So we're taking a pump and we're pushing it into a hose. So if the hose is too tight, it makes the pump work harder. So if we loosen the hose up and open it up by giving them a vasodilator, sometimes that helps a little bit, okay? Or they may need a pacemaker. So if things are a little bit dysynchronized, we can do a pacemaker as well. Activity limitations. This guy isn't going to do the Ironman, right? We're going to have, again, we're going to do the same education we do with heart failure patients, pacing themselves, making sure they get rest in between periods of activity, okay? We can even give them instructions on how to have relations with their partners and so forth, the better way to have sex, all right? Again, we have impaired central perfusion. The only thing keeping them alive isn't doing a very good job. So they have a limited lifespan if they're not going to follow instructions or have surgery, okay? All right. So dilated cardiomyopathy, you can see, this isn't the best picture, but if we have an enlarged left and right ventricle, then the heart's going to have trouble pushing out everything that's been pouring into it. All right, so we want to help that squeeze. We're going to give him a diuretic and hopefully reverse the cause. If it's something we can reverse, like if it's because he's glug drinking a bottle of Jack every morning, then maybe he can do some drinking cessation and work through that, and hopefully we can reverse some of those causes. All right, now we have hypertrophic cardiomyopathy. That's what you're going to see that a lot with patients with untreated hypertension and so forth. So asymmetrical septal hypertrophic obstructive cardiomyopathy can be considered obstructive or non-obstructive. Okay. So if we have an obstructed, that means that the outflow from the heart is somehow obstructed. So maybe we have aortic valve issue like aortic stenosis. Remember, if we have aortic stenosis, not only does it not close well, but it doesn't open well either. And if the heart has to push against a broken, like trying to get out your front door every morning and having to like kick it open, eventually that leg muscle is going to build up some muscle, right? It's going to go, and right? But it only has so much room in the chest, correct? It's only so much room in the pericardial area. So if you build up too much muscle, what's going to happen? You're going to impair the area you have to fill and pump. All right, so that's what we're talking about here. So if we have left ventricular obstruction is due to a bad valve, okay, there can be a genetic link here. All right, so do you have a picture? No, of course not. All right, so pronounced ventricular hypertrophy. What does that mean? We have a really thick, fat left ventricle, all right? So the muscle only has so much room in there, so it starts to move in on itself. And what used to look like this for filling time becomes like this for filling space. So we lose our filling space. So we go from this to this, all right? Exertional dyspnea. we're going to have signs of, guess what, guys? Heart failure. External dyspnea, orthopnea, paroxysmal nocturnal dyspnea, angina, fatigue, okay? And murmur. Mild cardiomegaly. All right. So we want to improve our filling, right? So we want to open up the space if we can, relieve the signs and symptoms. So beta blockers, verapamil, avoid vasodilators and diuretics, okay? So we want to improve systemic vascular resistance, but not cause vasodilation. So we don't want it to have to push too hard, but we want some venous tone, okay? We want to lower the heart rate. We don't want the heart to panic and start to pump too fast, because then it's just going to tire itself out even more. May proceed with a septal myotomy. So what does that mean? They can actually take some of the muscle out, all right? They can decrease an outflow obstruction, so they can do like a valve replacement, a septal ablation, a pacemaker, cardiac transplant. That's big time surgery, right? That's the big one. Again, they can do this by EKG, so we can see if the heart muscle is too big just by looking at how big our spikes are. A MUGA, we can inject them with a radioisotope and look at where it goes, or a cardiac cath. All right, these are the pictures I was looking for. I'm like, I saw pictures somewhere. All right, so see the hypertrophic? See how big the muscle is? Right? You know, yeah, it's been kicking that door open so often that the muscle just built up. It doesn't develop overnight, does it? No, my failed years at the gym have yet to produce muscles. So it does take a while, and it takes frequent work. Like this heart's been doing this for a long time. Sorry guys on the microphone, I'm walking over to the screen. So look how little filling space we have left. What do you think that does to our cardiac output? Oh crap, right? What is a normal cardiac output? Does anybody know? Any guesses? 5 to 8 liters per minute, right? Liters, right? That's how much blood per minute. That's how much our blood pumps a lot. It's measured in liters. So if we're losing a whole, like we've probably lost just on that cross set, let's say we lose 30 milliliters per pump. That's a lot, right? I'm guessing. I don't really know how much that heart's lost, but think about, it's a numbers game. So if we've lost cardiac output because of space, that's a big deal, okay? The heart has to work harder. There's more muscle too. Does the bigger muscle need more oxygen to stay alive? Yes. So all around, it's not a great situation. Okay. This shows the blood flow. So you can see in that middle picture the enlarged stiff septum, what that does. So sometimes they will go in and they'll actually do I can't say the name of the surgery, but they'll actually take some of that tissue out, all right? And then there's dilated cardiomyopathy, which is the opposite problem, which the heart is just big and floppy, so there's more fluid to push out, and it's dilated, so the muscle doesn't work as well, so it's a big floppy mess. And so we have too much fluid to push out and not enough tissue to push it out with, and they're going to show signs of heart failure. Okay, all of these patients are going to show signs of heart failure, which is why we always teach you guys heart failure first, because basically these are just variations of a theme. All right, and then we have the restrictive. This is the least common, all right? This is basically where we have lots of scar tissue and fibrosis. So the muscle itself is too stiff to really do its job well, okay? It leads to, her words, decreased compliance. All right, so it's hard to fill what doesn't pump well. So exercise intolerance, dyspnea, fatigue, right-sided heart failure, and mild to moderate cardiomegaly, okay? And we will have some mitral or a tricuspid valvular regurg, okay? I'm not gonna, no, not going there. Okay. All right, so how do we treat any heart failure? Oh, look, we're gonna help with the push, right? So DIG, diuretics, anticoagulants, because we're gonna have turbulent blood flow and a heart that's panicking and one that needs help pushing itself, All right. We want to improve diastolic filling. So we have systole and diastole. So diastole is when our ventricles are filling up with blood, so we want to improve that filling time. And again, it does depend. Everybody's different. How bad is this patient doing? All right. Do we have emboli development? All right. And for restrictive cardiomyopathy, again, chest x-ray. Can you see it? Is it big? Did we do a scan and we see that the blood flow is impaired? Or did we do a cardiac cath? All right. This is I like this. I'm a picture girl. You can always tell when I've done a PowerPoint because I put tons of pictures. I am a visual learner. So we have normal, we have our dilated, the ventricles are just too big and too thin and they don't do their job well. The hypertrophic, which is just the muscles impeding on itself because it's gotten too large. And then the restrictive, which the walls have just become too stiff and they don't move very well. Okay? All right. Oh, yeah.
In terms of the dilated, is there a way to improve the muscle tone in the heart to help with the dilated?
That's when they will put the patient on a really a good inotrope, like milrinone or So yeah, sometimes they can be managed medically for a while. If they become very, very sick, though, sometimes they'll go to something called an LVAD, which we'll go over in a later slide, maybe today, maybe not. But that's a left ventricular assist device. So sometimes we actually have to stick something on there that does the squeeze for the heart. And that's what a left ventricular assist device is. It squeezes for you. Or we can do a balloon, I'm going to tell you right now, balloon pump is the Hail Mary of Hail Mary pass for people in cardiogenic shock. When we talk about shock next time, it can help a little bit with cardiac output, but if you have a heart that's so sick that it can't even manage to perfuse itself and the patient's actively dying, and we put in a balloon pump, that patient needs massive interventions, like a new heart, now. All right. But yeah, we can. Most of the time, we medicate them. So they're going to get an inotrope, they're going to get a beta blocker, they're going to get diuretics, and you'll see that all not very different from heart failure, because it really, if you think about it conceptually, that's really what's causing the problem. If it's caused by a valve, we change the valve. If it's because the heart muscle itself isn't doing very well, other than changing their diet, hoping that things heal over time, if it's because of an alcohol abuse issue, hoping that they stop drinking. But sometimes we're just waiting to see if they improve, or to the point where maybe we have to go in and surgically repair that heart. Okay? All right. So the restrictive, I don't even know if I want to go over this slide very well. It's a type of restrictive, so a lot of the tissue of the heart muscle gets replaced by scar tissue, okay, and fat. And they're going to have symptoms of impaired central perfusion, like palpitations and syncope. They will fix that with an AICD, all right? So that's that automated internal cardiac defibrillator. So if they're having lots of cardiac ectopy, that device can prevent them from going into a lethal arrhythmia, all right? I think that'll make a little more sense when we get to that part, but she wanted to make a point with this one. All right, cardiac transplant. Are you gonna go into the OR tomorrow and do a transplant? No. And in fact, we're actually gonna be talking about the long-term care of a patient post any transplant when we go over protection in a couple of weeks. And it really isn't about it's a little bit about the organs we're replacing, but it's more about how we have to stomp all over their ability to protect themselves so that they don't reject the organ, okay? But let's talk about cardiac transplantation in terms of we have the whole pump is crap, we need to replace it, so the patient needs to have a transplant, okay? And if we have someone with dilated cardiomyopathy who's been managed for a while, but now is at the end, we've done all we can for you, Captain. We need to change this whole thing out. The whole thing's got to go. About 2,000 people a year in the United States. What's that LVEF? So left ventricular ejection fraction. How much blood that the left ventricle tries to squeeze out with each pump actually makes it out. So it's less than 25%. So it's really awful. Most healthy adults have an ejection fraction of around, 60 to 70%. So not the most, it's not a tight ship, let's put it that way, even in a healthy adult. But you decrease that, you've severely impacted that patient's cardiac output. They have, this is an impaired person, right? This is someone with severe edema. This is someone who may be on an LVAD that has to walk around. Have you seen the patients with the little purses with their milrinone, where they walk around and they're on a continuous milrinone infusion all day just to stay alive? These are the people on our transplant list, okay? So life expectancy of less than 1 year. So you have to be dying of your heart disease. You can't just go, I was thinking I'd like a new heart today. And go, I'll just swap out, go down to, Costco and get a new heart. You have to, it's severe. You have to show that you're sick. They have to prove that you're sick. Now that less than 65 years does depend, like, you had, a guy that was a marathon runner and he was super fit, and he ended up with, an infective issue that caused massive heart disease. That might be different than a different patient. So that 65 is sometimes a fluid thing. So the heart disease class 3 or 4, I'm not testing on anyone. Okay. No infections. What does that mean? So that means, like, if you are dying of severe HIV, end stage HIV, and you also have a bad heart, they're gonna go, that heart could probably save somebody else, and we might just switch that to somebody. So if you have an active disease that's killing you already, or a severe cancer, if you have stage 4 cancer, are they gonna give you a brand new heart? No, okay, that's what we're talking about. So you have to be dependent on an inotropic support, right? Like those people walking around with the continuous infusions of milrinone. Like, you need to, like, if we took that med away from you, you'd die. That's what we're looking at. Unresponsive to conventional therapy. So we tried everything else. We threw the kitchen sink at you, and your heart just did not respond to treatment, and you are actively trying to die on us, okay? No evidence of alcohol or drug abuse, right? And that's awful. It's awful. But there are so many people waiting for these hearts, and it's such a huge, also a huge commitment to have it, and you have to be able to follow the regimen to prevent rejection. So we just gave you the $1 million heart, and then you go down to Kennedy Plaza and score and decide that's how you're going to thank everybody for saving your life. No. So they're not going to give it to you if you're actively using.
So there's some kind of like 6 months criteria or something for them to be clean, right?
They have.
It's not like you've never used.
No. No, if you're clean,
For like certain amount
yeah, they're gonna let you have it, right? We forgive, right? But if they do, drug testing, and you're coming back positive every time you come in, they're gonna be like, sorry, you got to stop using the H before you come back in for your heart transplant. All right, and no evidence of. So if you have other end organ damage. So you're diabetic and you're on dialysis already, and you're waiting. They're probably not going to give you the heart. Like, you got to fix that other stuff first, okay? And obviously, we're going to go over this comparable weight. We're not going to stick the giant from Game of Thrones. What's his name? Clegg or whatever. He's like 6'8". We're not going to take his heart and put it into someone who's 5 feet tall. You have to be sort of compatible in terms of body size, and ABO compatibility. That's just the minimum. Like, you have to have the same blood type, and HLA. We'll go over that in the transplant class. All right. So this heart's, I can never say, is it denervated or denervated? Okay, we cut the nerves, right? When we cut out his heart and put it into you, the nerves get severed, right? So it's unresponsive to vagal stimulation, right? So usually it sets its own rate and it stays at that rate. So once the heart is in you, it stays at like a rate of like 60 something. And it doesn't speed up or slow down or speed up or slow down. Like that's the rate it's gonna be because it's not connected to your nervous system, all right? So they give you isoprel, atropine, beta blockers, okay, and chronic, okay. I said that wrong, sorry. So because it is not connected to your nervous system, some of the normal meds that we would give you to suppress things like beta blocker and DIG and all that don't work on you because you don't have, you know the heart meds that we give you, they act on the alpha and beta receptors of the nerves in your heart. And if the nerves aren't connected, are those meds going to work on you? No. Okay. So you may end up with some hypotension in the immediate post-op phase if you have a brand new heart, just so you know. I don't think if you have a brand new heart, you're going to be that worried about it. You're going to be worried about the big sternal incision. Okay. So prevention of rejection, we're going to go over this in the other class with cyclosporin and Imuran. If the new heart is being rejected by your body, you're going to show immediate signs of heart failure, okay? And they can do a biopsy to see if your body's attacking the new tissue. All right, here's the thoracic aortic dissection. It's acute and life-threatening. Who died of this? Does anyone remember who died of this? Was it really? I'm like, that was 15 years ago. Seems like such like yesterday. But John Ritter died of a thoracic aortic dissection. And some of you younger people are like, who's John Ritter? John Ritter from Three's Company. Again, totally aging myself. You know what I'm talking about. Okay, so he was on my 8 Simple Rules for my teenage daughter. Okay. He was a TV guy, and he was only in his early 50s, and he was complaining of not feeling very well, sick to his stomach, nausea, just weak, and thought he had the flu. And he stayed on the set of his TV show, and then when they finally brought him in, they realized he had a dissecting aorta, and he died. And it was a shame, because this is somebody who has millions of dollars and still, okay. So it's acute and life-threatening, let's put it that way. You can die. 90% dead if you don't treat it, okay? So what happens is the aorta, the intimal layers of the aorta separate, and then blood pools in there, and you get a big old bubble, and then if it bursts, it's your aorta, the largest, biggest vessel besides your heart, and then creates a false lumen of blood flow too, okay? So it can die. Every time the heart pumps, it pushes blood into that false lumen. All right, so it impacts it can impact your cardiac output too. And it may include other branches. It's so big, it may block off other branches of the aorta, so they may feel lightheaded and so forth, okay? Or it can cut off blood supply to your brain, abdominal organs, kidneys, spinal cord, and extremities. Kind of bad, right? You have a big old bubble of blood that isn't doing anything for you and is blocking blood from reaching other important areas of your body. All right? So here's a dissection. You can see it's a false lumen. You get area that of blood that just pools in there. It's not supposed to be there. It can get bigger and bigger and bigger, impair circulation. And then if it ruptures, you're in huge amounts of trouble, like poor John Ritter who died. Look him up when you go home. I'm so crushed. They're all looking at me like, who? John Ritter? I don't know who that is. All the moms at home who stayed home with their kids today know who I'm talking about. Okay. Clinical manifestations is sudden, severe pain in the anterior of your chest. So they have like a ripping pain. It's not like I don't feel well. It's like pain. Pain radiating down the spine to the abdomen or legs. Ripping or tearing, because that's literally what's happening to the aorta. It's ripping open. And it may mimic an MI. So if you have signs of an MI, like he started having signs of an MI, that's when they brought him to the hospital finally. But he was feeling just sick and poorly the whole day. And if you have an impaired pump, all those signs made the cardiovascular, neurologic, and respiratory signs. Poor guy. I love John. All right. So that's when so to see that, if you see a big bulge sticking out of the aorta on a chest x-ray or during an echo or the first scan, that's why they like to do that picture before they start shooting dye in, because the pressure of the dye may actually cause a rupture of if you have one.
So what's the difference between dissection and aneurysm? That's what, yeah. This kind of seems like
The aneurysm is the bubble.
right.
The dissection is the popping of the, okay.
So, okay.
An aneurysm is just a pocket that's just bulging out. The dissection is the part where it branches off and
So but you're saying that the dissection can actually burst, though?
it can.
Is that then it changes to be an aneurysm at that point, or?
Yeah.
Like a
Ruptured. Okay. Aneurysm's just outcropping by itself can pop. Dissection is when there's like an actual rip in the lumen and it starts to fill. It's just how the bubble fills up.
Okay.
Don't have.
Does it usually, would you describe a dissection as happening faster than an aneurysm?
It can.
An aneurysm can occur over time.
Right, an aneurysm can have, John Ritter started feeling poorly in the morning, and then by the evening he was dying, okay? Aneurysm can happen over a period of years, and they can be just silent,
Right.
just sitting there.
Until it actually
Yeah.
pops, in which case it's usually very sudden and usually
Yes.
results in
Yeah.
death. Yeah.
Yes.
Got it.
Okay. All right. So here's our dissecting thoracic aortic. I think you guys get the picture, though. We have an extra lane of traffic that's a dead end on 95. What's that going to do? They just open an extra lane and then they cap it off so that nobody can. What's that going to do to the blood flow in the area? You're going to get a gigantic traffic jam, right? And that's what happens. And it happens. The dissection can happen quickly and cause symptoms. So he had symptoms throughout the day, wasn't feeling well, and then he died. All right. So, how do we see it? Chest x-ray. Do you have a big old bulge? Something going on? An echo or a transesophageal echo. CT. So if they just brought him in and done an image to see how, they would have seen it right away. Or an angiography, which is just where they put dye in through one of the major vessels and then they watch the flow. Okay. All right. So collaborative care. All right. So why would we want them not to have a high blood pressure? Right. While this is all going on, we don't want this baby to pop, because that's, if it's dissecting, we want to manage it until. Is this guy, if we catch it, is he going to the OR today? Oh yeah. Yeah, he's going to the OR. But we don't want it to burst. We want it in a controlled setting. Right? We don't want this thing to burst and then have to spread his chest out in the emergency room like in an episode of ER or something, okay? We're going to give him a beta blocker like esmolol or metoprolol. Again, LOL, those are beta blockers. Calcium channel blocker like verapamil, okay? Sodium nitroprusside or nipride, that really drops your blood pressure. Or an ACE inhibitor. Okay, we want to lower blood pressure so there's not too much pressure going on in that dissection while we get him ready and prepped and send him to the emergency room. OR.
I feel like I had a patient like this the other day in the ER, and we were giving him a fairly good amount of pain medications as well, because when your pain increases, your heart rate increases. You do have a life hack to Rhode Island.
Yeah, oh yeah. Yeah, that's not a Kent surgery. No. That's a Rhode Island hospital. Yeah. 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 So, right, it's a ripping, tearing feeling mimicking an MI. So horrible, horrible chest pain. So what's the drug that we like to give for that? Morphine, our good old friend morphine, and makes them feel good. Okay. All right. So surgical intervention. So we have to clamp that sucker off and resect it. All right. Sometimes we graft it, meaning they take a new section of vessel from a donor and put it in there. Endovascular grafts, all right? They can do percutaneous. If it's a small, they can actually go up more and more. If you're ever interested in a really cool advancing area of nursing, interventional radiology is the bomb nowadays. They're doing more and more stuff through the large vessels. So they go up through your femoral and they feed these catheters up, and they're able to do more and more intravascularly. So, like an implanted, so they can actually go up and sort of patch it from inside. And so instead of opening you up, now is this still a procedure? You need sedation, this is a big time thing, and the cardiologist is there, and you want the crash cart right next to you. Oh yeah, this is a big deal. But it's not as bad as having your chest cut open. So there's a lot more stuff. So if it's a small one, sometimes they can go in and do the intravascularly. Post-operative care. Okay, so you had heart surgery or surgery right next to your heart. That's ICU, right? When we used to take care of the aortic repairs, that's at least 24 hours in the ICU, at least. Intense monitoring, Q1 hour vital signs, cardiovascular, renal, neurologic status. Where's the first place we're going to see outside the body a drop in cardiac output? The easiest place to note that maybe their cardiac output, other than vital signs, isn't that great. Urine, your pee-pee bag. So that Foley bag, that's why in an ICU almost everybody has a Foley. Not because we don't feel like making everybody pee and get up. It's because that's how you monitor how well a patient's organs are being perfused, is their urine output. So they're really going to be watching that close. What's a good number for an adult patient? 30 mLs per hour, right? For an adult. And we know how to I know you know how to calculate this for babies, right? It's that 1 to 2 milliliters per kilogram per hour. That number works for adults too. So if you have a really big adult, you can do the calculation. But for most adult patients, we do the 30 mLs per hour is probably pretty good. Okay. And neurologic status, because of your cardiac output, the brain isn't getting perfused either, and you're going to see neurologic changes. Okay. How are we doing on time? Okay, we're good. All right. Cardioversion. So, what is cardioversion? It's a shock, right? Is it as big a shock as we give someone who's dead? No. No. It's a little shock. Happier shock, a little shock. And it is synchronized. So it's an electrical countershock. So we're rebooting the computer, right? So the heart, the electrical system isn't working as well as it should, or there's extra ectopy, meaning areas. Remember the cardiac cells, every cell in your heart has the ability to generate an impulse. And if you have a bad one that's doing things all on its own, it can cause a weird electrical rhythm. So sometimes we zap it, and like hitting your kid, like shut up, and we tell it to go away and be quiet. My kids will tell you straight out. Yeah, I'm a swinger in the back seat. My arm goes back there, and I'm like, shut up. They're all big now though, so I can't do that. And we convert them hopefully to a stable normal sinus, right? It's so if you're not dead, it's an elective procedure. That's how I like to think about it. So if you're dead and you're okay with it, we will bring you back to life. So that's not an elective procedure, that's a life-saving. But if you're alive and sitting up and we need to zap your heart, then you have to say that that's okay, right? Like, okay, you can electrocute me a little bit. So informed consent is needed. We can't just do it. You have to sign a paper that says it's okay for us to zap you. Does it feel good? No. I've been in a bunch of these, and it cracks me up a little bit. But everybody's like the same thing. So you want to give them a little Valium, a little Versed, just to, and digoxin is held 48 hours to prevent post-cardioversion arrhythmias, ideally. In an emergency, like if you come in and you're tacking away and you need to be cardioverted, they're not going to go, We need to wait 2 days. But ideally, if it's a routine, like you come in, then they'll hold the Johnson. Okay. So voltage required is 50 to 200 joules. Okay. So do we start at the 200 and go, let's see what happens? Let's shoot for it. You want to shoot for a high number? No. You give them 50 and see if that does what it's supposed to do, and then you go up. They feel it. It hurts. It's not like dying pain, and how long do we shock them for? Is it like, it's like, bloop, and they go, ah, and then, it's over. It's synchronized with the monitor. So on all cardiac monitors that do defibrillation, you'll see a synchronized button. And what that does is the computer anticipates when the next QRS is going to occur, and ideally it will zap on the QRS. Why? The last place we want to zap somebody is on the T wave. All right? T wave is what's called the refractory. That's the sleepy time. Your heart doesn't get a lot of sleepy time. Your heart gets very little sleepy time. Very little time to chill. And that's during the T wave. Okay? And if you wake it up during the T wave, it gets very, very angry. All right? And we end up with a lethal arrhythmia when we do that. So if we zap on the T, we're going to end up in like a VTAC or a VFib. No VTAC, no VFib. So we want to cardiovert on the QRS. So that's what that synchronized means. All right? All right. Oh, she has it on the slide. I did look. I have notes. I write all this stuff out, and then I don't bother to look at my notes. I don't even know why I bother. I never like to read my own notes. But if it takes place during the vulnerable period, the T wave, sleepy time for your heart, we can end up with a VTAC or VFib. All right. Okay. Rut-row, we have someone that comes in ventricular fibrillation. We're going to go over this in adult code, because what's going on if our patient is in ventricular fibrillation? The patient is dead. We have no pulse. This is a dead patient. So we do that a little differently. We code them. So that's what defibrillation is, okay? We defibrillate dead people. And we have a whole 4-hour class set up for that one, all right? But we have biphasic defibrillators that deliver this at 150 to 200 joules, all right? We have old ones, like the ones at, some of the nursing homes, if they have them at all, that included a shock of 360. All right, so the old ones were monophasic, meaning the electricity only traveled in one direction between the now we have the biphasic, and it goes between both, and it's a little better. So we can use slightly lower amounts of energy because it's being delivered more efficiently. Okay. If the patient's dead, we usually just do whatever the maximum number of joules are. That's not when you take baby steps. Oh, he's only a little dead. We'll start low. No, dead is dead. So we usually do max joules, and if they're dead, we bring them back. Okay. So it's similar to cardioversion, but can we synchronize this? No, there's nothing to synchronize with. They're dead. So what we're hoping is that we reboot the whole system and the electricity comes back, right? Cardioversion does use a whole lot lower amounts of energy. Remember, we're doing like 50 joules versus 200 joules for someone who's dead, right? So if they're alive, we only give them a little shock. If they're dead, we give them a big shock, all right? All right. And cardioversion is only done by a cardiologist, okay? What do I mean is only done by, okay, who can shock a dead person? Anybody could shock a dead person. They have them in the airport now. Grandma could shock your grandpa if he keels over with an AED, right? So you slap the pads on, and then anybody can do that. A living, beating heart, only a cardiologist shocks that one. So we set the defibrillator up, we hit the sync button, we advocate, and we make sure our patient has some happy Versed or Valium, and they're feeling not too bad. And we've explained this whole thing and done it very calmly. And then who pushes the button? The doctor does it, because we're shocking a living heart. And luckily they're already on, like, they have their pads on, because you don't know what's going to happen. It usually works out fine, by the way. Usually it shocks, and then there's a little delay, and things come back, usually. But can it go badly? Absolutely. So I always feel, oh, okay, well, at least we got the pads on, and we can step right in, right?
You also want to make sure you have that signed consent form too, right?
Yes, absolutely. Sign informed consent. And can we give the Valium and then get the consent? No. It's got to be informed consent, not semi-conscious consent. It's got to be informed consent. You got to get that before you give them the Valium. Sign this, and then I'm going to give you some Valium. All right? Okay. Place paddles. Paddles. We're going to use the pacing pads. Okay? Okay. All right, so after use, we're going to turn the machine off. We're going to go over all this in our code class. If you're going to shock somebody, we do not want oxygen blowing across the area where we're going to be firing an electric charge, just in case of fire. It does happen. And are you going to monitor your patient who's requiring electrical stimulation to fix their heart? Duh. But yeah, vital signs, airway, level of consciousness, all the stuff we always do. All right, so if we're successful, if it actually worked, we're going to have conversion to normal sinus rhythm. Yay, right? Adequate blood pressure, stable peripheral pulses. So one of the things, the ones I see the most often for cardioversion is SVT, right? So we're going to go over that a little bit again. But SVT really it stands for supraventricular tachycardia, meaning that it's the ectopy comes from above the ventricles. That's all it means. So one of the atria is running the show. So what size QRSs do we have? We have narrow. Like I like to tell my other classes, we want thin QRSs, so like a size 10 or less. Like not that I'm larger than a size 10 myself, but I'm not a thin person. So we want a relatively slender QRS. So women, a size, sorry guys, but most of them are female. Your wife can tell you. So size 10 or less. So 10, right? 0.10 or less. Thin is from the atria, unless there's a heart block going on. Oops. All right. So SVT, what are our symptoms of SVT? So you have a heart rate of what? Let's start with that. You can go anywhere, it's above 150, 160, depending on the textbook that you use. So is that fast? Super fast. So super fast heart rate. And sometimes patients, there's a typical SVT patient we see in emergency rooms. She'll tell you, 40, couple kids, huge, what?
I have a 20-something-year-old who comes in fairly, I've seen at least a few times a year, and
Yeah.
he walks in and he's like, yep, and I'm like, you don't even stop anymore and do like the standard things. I'm like, yep, you're just gonna go back, because he's always like 240s to 280
Yep.
every time.
So the typical SVT is like middle-aged woman, caffeine habit, lots of stress, comes in feeling a little unwell. Or you can have your young, anybody can do it, but there's like a cohort of patients that the typical presentation, and they come in, they sit them down, they put them on the monitor, and they're going at $1.80. You're like, woo, 180, and they're like, yeah, I just feel a little, I don't know, I can't catch my breath, just a little out of breath. And then you're like, yeah, I bet that probably feels, or they feel palpitations, or sometimes though there are people that are asymptomatic, believe it or not, and they just feel like their heart's racing. Oh yeah, it's racing all right. Okay, so what we can do, we can cardiovert that patient, but do we go straight to the juice? Okay, depends. All right, guy walks in off the street, yo, I feel like I have my heart racing, and he's doing okay otherwise, then we can do something like a vagal maneuver, like have him bear down. You can try the ice on the bridge of the nose that stimulates the diver's reflex. Or we can give them medications. Like, what kind of medications would we start with? Maybe. We can try a beta blocker, but the one that we talked about adenosine, ding, ding, ding. So 6 milligrams, which is basically the chemical equivalent of the shock. It shuts everything down briefly and it reboots. Okay, so we can give them adenosine. If that doesn't work, or the patient's rolled in on a stretcher, semi-conscious, barely a blood pressure with the same heart rate, that's when we would start with the shock. Life-threatening, doesn't have enough cardiac output to maintain like normal level of consciousness, that's bad, that's life-threatening. So we will shock that before we do all the like, oh, can you bear down a little bit? You know, life-threatening, we're going to intervene immediately. Okay, you'll see that when we start, we go back to adult code in a few weeks, or next week, or whenever I scheduled it. When we do our adult code class, you'll see the algorithm. I love those algorithms because they're easy to follow. If he's this, do this. And they're great for students to kind of put these, oh, what's the next step? Oh, follow the algorithm, because that's what everybody does everywhere. Okay. Oh, stable. So if you have cardiac output, you're going to have good peripheral pulses too, right? So an AED, we were just talking about that, right, at the airport. Anybody can shock grandma now. So AEDs are defibrillators that have rhythm detection capability. There's only 2 dead rhythms, like a dead person, that we shock. Does anyone remember what they are? VFib and VTAC. That's it. We don't shock because there's no point in shocking the other rhythms. We used to shock asystole too, and then it just doesn't do anything because. So AEDs are defibrillators that have a rhythm detection capability. Okay, they're hands-free. All defibrillators, by the way, should be hands-free. The ones with the paddles, like, and it's incorporated in both the BLS and ACLS courses for healthcare providers. Okay, could you potentially be asked on like your NCLEX? What capture is and sense and so forth. You probably could be, but I'm more interested in what the patient's going to look like and how you're going to handle it, and the fact that what the patient's going to look like in the bed and how you're going to care for them and what kind of teaching. So while they have a temporary pacer, they need to be aware that they're going to be connected to this machine, that we're going to be taking extra good care of that IV site, that they're going to remain on a cardiac monitor the entire time that pacemaker is making their heart beat for us, all of that, okay? All right. Okay, so the pulse generator, that's the supply. So do they have batteries in them? Yeah, they absolutely do. All right, I can see I'm losing some people. So I'm going to pause for a minute. Okay. So she has all these parts on here. I'll let you read the definitions. Temporary, permanent, demand, fixed, okay? Those are, they're just the modes. Like, does it sense the intrinsic electricity and stop, or does it override? Like if we're trying to slow something down, it'll override with using a stronger impulse. So if someone's, we can use a pacemaker if someone's heart beats too fast as well. We can override and say, nope, 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 you're gonna go at my speed by giving it a little extra juice to do so, okay? And is it a temporary or permanent one? Remember that the temporary is literally just a wire that's floated into the heart, and it kind of just hangs in there and shoots off of some electricity, and you get a QRS complex from that. All right. So, the temporary, we use emergently because it's temporary. So if we have a patient with syncope, what's syncope? That's fainting. That someone doesn't have enough cardiac output to get blood to their brain and they pass out. Or signs and symptoms related to bradycardia. So if you have someone come in and their heart rate is 30 and they don't have good cardiac output because of that, and they're hypotensive and weak and so forth, okay? Or they have a really fast tachycardia and we want to override that. And a heart attack or a heart block, okay? So we have transvenous. So that's placed through the vein. That's the one with the wire floating in the middle of the heart. Then we're going to have transthoracic, so through a chest puncture. So actually poke a hole through, and a pulmonary artery catheter, okay? Then non-invasive, transcutaneous, so that we can use the pacer pads on the defibrillator. So they would put a pacer pad on the front of the patient and a pacer pad on the back of the patient, and they literally set the electricity, and we can capture using the defibrillator. How comfortable is that? Not, because you need a much higher dose of electricity using transcutaneous pacers than you do with one with the wires actually touching the muscle, right? Okay, so transcutaneous. So electrodes are placed on the back, chest and the back, external. All right. The actual battery and the settings are in a device outside of the person. That's what she means by the pulse generators outside of the body. So there's a handy controller or the actual defibrillator machine that we're using to control that, okay? Unlike, so we're gonna set the rate. How fast do we want the heart to beat? All right, the milliampules, that's the electricity. It varies, how high we have to set it varies patient to patient. So we watch the monitor and we watch the patient while we play with the dials. And sensitivity, so if it's asynchronous, meaning it doesn't matter what the heart's doing, or synchronous, meaning we want it to work with the heart, so an electrical beat, that's the sensitivity. We will set that. All right, so here's some pacer spikes. So, I don't know if you can see my mouse. Oh, here's my mouse. All right, so what do we have? We have a pacer spike. It's hard to see, but we have a pacer spike, and then we have a tiny little P wave, and then we have a pacer spike, and then what does this look like? QRS. And is it thin? Is it size 10 or less? Or is it fat? Yeah, it's more like me, right? So it's a little bigger, fluffier. So it's a wide QRS. Why? Because we zapped it directly on the ventricle, right? So whenever the ventricle is responsible for doing its own thing, you're going to have a wide QRS. So we have it really is hard to see on this, but you have a tiny little P wave right here, which is preceded by that spike. So spike, P wave, spike, big QRS, all right? And that means this device there's a wire going to the atria, and there's a wire going to the ventricle. There's two wires. So if you see two spikes, there are two wires, okay? And out here, this is what a temporary one looks like, the box. And you'll see, like, this isn't like letting your kid play with the remote control either. Like, there's a cardiologist, we're all watching the monitor, you're very slowly turning dials, they'll tell you when to stop. All right, temporary pacemakers. So, we can have complications, right? This is a temporary fix, failure to pace. So maybe the battery, Oh, and sometimes you get the confused patients that themselves think that this is the remote control or a phone, and so they have this little slide over plastic cover, and you're supposed to keep it out of their reach, so that they don't accidentally, hello, can I have some coffee? No, and then failure to capture, we want to make sure that it's connected well, and failure to sense means that it's firing in the middle of the patient's own electrical beats and things like that. All right, permanent. Permanent meaning they went to the OR and we placed a foreign device inside their body. So things like sinus pause or sick sinus, whereas the intrinsic pacemaker, the SA node, isn't doing its job very well. Bradycardia. Symptomatic second-degree heart block, QT prolongation, sick sinus syndrome, complete heart block, okay? I've seen patients, 20-year-olds need pacemakers from Lyme disease, complications of long-term Lyme disease. That's one of those long-term cardiac issues that can come from Lyme disease when it's undetected. All right. So the first letter, so V, ventricle, A, atrium, D, dual. or O, none. So where do they have the wires poking in, okay? Sense, so again, ventricle, atrium, dual, or none. Sense response, triggers pacing, inhibits pacing, dual, or none. Okay, so commonly used modes would be atrial demand pacing. So we want the atria to be triggered. The atria then fires off. You get a normal P wave, and then you get a QRS, because there's probably no problem with the electricity traveling within the heart. It's just that the SA node isn't doing its job. So we override that, and we tell the atria what to do. Just like I do with my husband, right, and trash day and all that. He once he's told what to do, he does a good job, but he has to have someone tell him what to do. Okay. VVI, ventricular demand. So we want to tell the ventricles directly. DDD, which is that dual. So that's when you're going to see the two spikes. So we're going to tell the atria what to do, and we're going to tell the ventricle what to do. All right. And then atrial asynchronous pacing, if we still want to have that atria just kick in, but we don't care about it being synchronous, so it's asynchronous. Okay. All right. I really want you to... I would like you to know the difference between the atrial ventricular or the dual, okay? So especially because that's really what the important part is for the nurse. So when you're looking at the monitor, what should you be looking for? So if you know, for instance, that your patient has a dual pacemaker, so two wires, atria and ventricle, you should be looking for two spikes. And if it's set at a rate where the patient isn't supposed to have their own intrinsic anything, you should see one before, like you should know roughly what the settings are and how many spikes you should see on the monitor, okay? Unless you go into this line of business and you're specifically going and helping them set these things. Most of the time, nurses will have no idea what kind of pacer the patient has, other than he has a pacemaker. All right, they don't always come in saying, "Oh, I have model XKQ, dash," and you look it up. You have no idea. Well, how do I know if my patient has a permanent pacemaker if I don't even look at the monitor? Because they have a box or something sticking out of their chest, right? And oh, okay. A special word, a point too. Do we ever want to put those defibrillator pads on top of that? No. So if they have a box or a port, something protruding from their chest that you can feel, you're going to make sure you don't put the pads directly on top of that. Okay? All right. Okay. So we stuck a foreign item into your body through a vein, or we opened you up and stuck one in, and we stuck wires close to your heart. So we can have infection, right? So systemic or local. So you can end up with a cellulitis, or you can end up with sepsis. Pneumothorax. So this can happen a lot with those temporary ones when we're floating a wire through the heart. Whoops. Sometimes it can go through and poke a hole through a lung. The wires can migrate and do the same thing, so we can end up with a hole in one of our lungs. Myocardial infarction, unfortunately. Okay. Hematoma. Again, jam the wire in the wrong place, and now we have a big old boo-boo. And dysrhythmias. So we're generating an impulse maybe in the wrong place for that particular patient. So you can put them into just as many lethal arrhythmias as you're trying to fix when you're doing these types of interventions. Those when they're putting in a temporary pacer, I always kind of hold my breath, like while they're putting it in. And the doctors are teaching some resident, and they're like, "Oh, look at this! Look, just watch." And the whole time I'm like, "Oh my God, I don't want to do compressions." I hate compressions. I love the defibrillator, and I like pushing meds, but I hate compressions. I almost always, you do them right, you feel those ribs crack, you're like, nope. Ugh. All right. So signs and symptoms of failing pacemaker. All right, bradycardia. So we put in a pacemaker to make your heart beat faster, and it's not doing its job. You're going to have bradycardia. Hypotension, because you don't have good cardiac output. Fatigue. spikes with no QRS or no P wave. So you see spike, but we don't get the result we're looking for, okay? Or no pacemaker, the battery died, or we fried it with a microwave, or palpitations or skip beats, ventricular tachycardia, hiccups, or muscle twitching. Why? Because it's electrical and the wire touches the wrong muscle, you're going to get a different muscle doing it. So yeah, they can get diaphragmatic muscle twitching. Spikes that fall where they're not supposed to. So the sensing may be off, where it doesn't understand that the heart's trying to generate its own impulse, and it may fire a spike. And remember, if we fire on that T wave, we can end up with a lethal arrhythmia. Pacing at a slower than the set rate, or a decreased, I would think if you need if you need a pacemaker, you may have some decreased exercise intolerance. I'm just saying. But if it's not working, you're definitely going to have some decreased exercise intolerance. Permanent ones. Okay, we just sort of talked about this. It's implanted in the chest within the muscle, right? In the right or left, underneath the one of the clavicles. So they can actually, these are getting smarter and smarter and smarter now. So they can actually be reprogrammed, like from outside, like, hello, you know. Sometimes they have apps for these things, which I think is really cool. We want the patient to be savvy though. Like, what does your pacemaker do? What should you not do? If you don't feel well, you need to call the office, or if you feel like chest pain, you need to go to the emergency room. Signs of an infection, right? Palpitations, so forth. They need to carry an ID card, and you tell them that, and then they show up at the emergency room without the ID card, and they have no idea what kind of pacer they have. Avoid contact sports. Duh. No, I think I'm going to take up boxing after I get my pacemaker put in. All right. So they should carry an ID card. While it is healing, while all those sutures and everything is healing, there are some activity restrictions. Do we want them taking an aerobics class and go woohoo and moving their arms and all over the place while all that stuff is healing? No, because it can dislodge the wire. So while we want them, you know, they can move around and do stuff, but we don't want them to do extreme movements while that stuff is still healing. All right, so here's what a normal pacer, so this is atrial pacing, remember? So this is me, you know, my alarm clock waking me up, and then once I'm up, I can tell the rest of my family to do their job, right? So here's the pacer spike, and then we have the P wave, and then once that starts, the rest of the QRS and the T look normal, right? Right, so my alarm wakes me up, and then I get everybody doing their job. All right, that's what normal pacing is for atrial pacing. Do I see a spike before the QRS? So this mode is what? This is A, right? A for atria. Okay. All right. Now, this is ventricular pacing. All right. So this is just the ventricle being stimulated. Do you see a P wave anywhere? No, because we didn't stimulate it. So whenever we're just stimulating the ventricle, the QRS is going to look like a PVC. It's going to look wide. It's bigger than my size 10, right? They're fat QRSs. So see how fat this is? You can see so look how, so we have at least 1, 2, maybe a half a box. So this is, she's a size 12. So she's a little fluffy. Like, we all love people like that. So she's a little fluffy, but we don't see any other spikes. So this is, what mode is this? It's V, right? Ventricular, that's it. All right, now we have our twofer. So we have this is me getting woken up on my alarm, and then there's my P wave, and then this is his alarm waking him up, and then we have our wide, look at that, wide QRS. So whenever we shock the QRS directly with a wire, you're going to get a wide QRS. The only one you don't see that in is that A mode, because who wakes up the ventricle? The regular cycle just flows through. But if we have the AV, spike, P wave, spike, QRS.